Good evening, everyone, and welcome to our webinar on the benefits of re-esterified omega-3 fatty acids for a healthy ocular surface. My name is Sarah Abata, and I'm the Director of Sales Operations here at PRN, and I'll be your moderator this evening. Tonight we are privileged to be joined by a special guest lecturer, Dr.Alice Epitropoulos, a board-certified and nationally recognized ophthalmologist who specializes in refractive and cataract surgery. She's one of the co-founders of the Eye Center of Columbus, one of the largest dedicated eye care centers in the country, and served as a clinical assistant professor at Ohio State University. In addition, Dr. Epitropoulos is the author of numerous published articles and has presented at several prominent national eye meetings. We are also thrilled to be joined by PRN's own Chief Medical Officer, Dr. Michael Gross, a nationally recognized expert in clinical nutrition. Dr. Gross is also one of the patent holders for one of our omega-3 formulations. Tonight's webinar will highlight a recent study published in the September 2016 issue of Cornea, which Dr. Epitropoulos is the lead author. So without further ado, please welcome Dr. Epitropoulos.
Thank you so much, Sarah. Would you mind advancing the slides for me?
Sure.
So I really would like to thank everybody for joining us tonight, and I am very honored to be presenting with Dr. Gross. I'm going to be reviewing the clinical importance of diagnosing and treating the ocular surface prior to cataract or refractive surgery. Go ahead and advance to my disclosures. And these are my financial disclosures, and I am a speaker and consultant for PRN. So technology has had a major impact on the advances and success of cataract surgery. But really, these advances can be lost when the ocular surface is not optimized. As we all know, ocular surface disease is the root of what causes many of our patients to be frustrated or dissatisfied or unhappy with their results after cataract or refractive surgery. Go ahead and advance. MGD is extremely common. It's the leading cause of dry eye and is the most common reason why patients see their eye doctor. This is a progressive disease, and if it's not treated, can lead to glandular atrophy and loss of function. Data shows that if we can get to these patients before they have severe damage, then they're going to respond better than if you wait until the glands are atrophied and non-functional. Go ahead, next slide. So the tear film is the most important refracting surface of the eye. An unhealthy tear film can cause unpredictable preoperative measurements. It can delay healing postoperatively, and it can also result in suboptimal outcomes after cataract or refractive surgery. So there's several factors that can contribute to exacerbation of surface disease after surgery, whether it be cataract or refractive. Damage to the corneal nerves can lead to neurotrophic dry eye with either of these procedures. Next slide. Toxicity from drops that we use, from the preservatives in the drops, is another reason why dry eye symptoms can worsen after surgery. So it's very important to try to use drops that are friendly to the ocular surface. And, you know, I think that there's a lot of research currently being done. There's a lot of, therapies in the pipeline that are coming up with different drops, different delivery systems that are, not very toxic to the surface. Delivery systems such as, intracanalicular plugs. We were part of the phase 3 clinical trials for Dextenza, which is a slow release of dexamethasone using an intracanalicular plug. So I think that, it's pretty exciting pipeline. So how prevalent is dry eye in patients undergoing cataract surgery? Bill Trattler presented this data at ASCRS, and this is known as the PHACO study, which is a prospective study looking at the prevalence of dry eye in patients undergoing cataract surgery. And the results showed that 87% of patients scheduled for cataract cataract surgery were diagnosed with dry eye, and only a minority of these patients had a previous diagnosis of ocular surface disease. Visual complaints such as blurred vision was more likely than typical symptoms of discomfort or foreign body sensation. So this study also showed that clinical signs of dry eye are very common in patients scheduled for cataract surgery. As you can see on this graph, more than 60% of patients had an abnormal tear breakup time, and 77% had corneal staining. So this study really stresses the importance of actively looking for ocular surface disease in our pre-surgical patients. So what are the consequences of proceeding with cataract or refractive surgery in patients that have an unhealthy or an unstable tear film? Well, we may select the wrong IOL power. We may not correct the proper axis or magnitude of astigmatism, whether we're performing LRIs or implanting a toric IOL, or even correcting astigmatism using the excimer laser. So all of these can affect our visual results and surgical outcomes. So it's important that we thoroughly evaluate for dry eye and blepharitis to maximize our patient outcomes. So all my patients, we kind of have a protocol in our office, and all my cataract and refractive patients fill out a speed questionnaire. This has been very helpful when evaluating for dry eye. Patients fill this out in the waiting room. It takes them less than a minute to complete. This is a validated dry eye questionnaire, and it can be used to evaluate and document the response to treatment over time, whether it's with using drops such as Restasis or Xiidra or LipiFlow or any other treatment, including the omega-3s. So current options of evaluating and diagnosing dry eye have changed dramatically over the last several years with point-of-care testing with improved specificity and objectivity. And these are some of the more objective tests that I'm currently using in my practice. Next slide, Sarah. So tear osmolarity is an excellent and very accurate measurement for evaluating dry eye severity and therapeutic response. But this should be used as a tool and in conjunction with other tests. Ocular surface disease results in hyperosmolarity, which in turn contributes to an unstable tear film, which is the hallmark of dry eye disease. So there was a study, a multi-center clinical trial, where we evaluated the effects of tear osmolarity on the variability of K readings and IOL sphere calculations in preoperative cataract patients. 25 patients had normal osmolarity and 50 patients were hyperosmolar. Next slide. So we showed a statistically significantly higher variability in average K readings in the hyperosmolar group, and 10% of these hyperosmolar patients had a difference in calculated IOL power of a half a diopter or more, which can be pretty significant, especially if you're, implanting a premium lens. Vector analysis of K-SIL showed 17% of hyperosmolar eyes had greater than a diopter cylinder difference between two pre-surgical visits. Go on to the next slide. So treatment should be tailored to the severity and type of dry eye disease. And these are some of the common forms of treatment that I use in my practice. Next slide. Using a good quality omega-3 has become a primary therapy for my dry eye patients. These nutritional supplements have been shown to decrease inflammation, increase tear production. It's also been shown to speed up epithelial healing and visual acuity after surface ablation, and may potentially help with regeneration of the corneal nerves. Next slide. In fact, two of the very prominent studies on ocular surface disease, the DEWS and the International Workshop on MGD, both recommend omega-3 supplementation as part of the management for aqueous deficient and meibomian gland dysfunction. Next slide. So as Sarah said, there was a multi-center, prospective, interventional, randomized, placebo-controlled double-masked trial, which we published in September's issue of Cornea. Next slide. And I'd like to acknowledge my co-authors for their contributions. And Mike Gross should be listed on that list, too. So 105 patients were randomized to receive either 2 grams of re-esterified omega-3 versus placebo. Next slide. So the primary endpoint was to determine the effect of PRN, dry eye omega benefits, which is an omega-3 nutritional supplement, on tear osmolarity. We also looked at several secondary endpoints. There were 2 other objective endpoints in addition to tear osmolarity. That included the MMP9 and omega-3 index score. And we also looked at tear breakup time, OSDI symptom score. We looked at Schirmer's. We looked at corneal staining. We looked at MMP9. In fact, Ben Sullivan, who is the scientific officer at Tear Lab, said this is probably the most well-designed and executed study that he's seen in the last 15 years of doing dry eye studies. So it's a very well put together study. Next slide. So let's look at some of the results of this study. First, let's look at our primary endpoint, tear osmolarity. Both patient groups started with a high osmolarity of approximately 326, so patients were fairly dry to start with. Next slide. At week 6, there was already a statistically significant difference in tear osmolarity between the study group and the placebo group. Next slide. And at week 12, it deepened to a p-value of 0.04 between placebo and the PRN triglyceride form of omega-3. Change in baseline we see here is a reduction in osmolarity of 19 milliosmoles over that 12-week period. Next slide. There was a significant reduction in MMP9 positivity. Next slide. And as far as symptomatology is concerned, using the OSDI, both groups started with a similar score. And at week 6, there was no change in symptomatology, which is expected since symptoms take longer to resolve than signs. Next slide. And as you can see here, at week 12, there was a significant difference in symptoms with a p-value of 0.002. Very statistically significant improvement in symptom score. And you can see that the change in baseline in OSDI here, symptoms reduced by 17 over this time period compared to 5 in the control group. Next slide. So we also showed an increase in tear breakup time between week 1 and week 6. And then the next slide. And again, this became clinically significant at week 12 with a p-value of 0.002 in the group that received the triglyceride form of omega-3. And this improvement in tear breakup time really shows an improvement in tear film stability. Next slide. So tear breakup time at baseline was 4.78 seconds and increased to 8.25 seconds, which again is an increase of 3.47, which was statistically significant. Next slide. So finally, the omega-3 index, which many of you might not be familiar with, this measures the omega level in the plasma, indicating good absorption. So this showed that both groups started with an omega index in the 4s. And then next slide. By week 12, there was a statistically significant difference going up to 7.19, which is an increase of 3 from baseline in the omega-3 group. Next slide. So we're very proud of our results. We met both primary signs and symptom endpoints prospectively. The results demonstrated a significant improvement in tear osmolarity, OSDI symptom scores, omega-3 index levels, and a reduction in MMP9 positivity. So we also demonstrated a more stable tear film as evidenced by a significant improvement in tear breakup time. So this study really changes the way that we manage dry eye disease and meibomian gland dysfunction. The results of this study support the recommendation that re-esterified omega-3 supplementation should be included as a primary therapy for dry eye disease and MGD. Next slide. So reducing the inflammation of the ocular surface is our primary goal in treating moderate to advanced dry eye disease. Cyclosporin has been shown to increase the production of patients' own natural tears, reduces corneal staining. Clinical trials also showed a 200% increase in goblet cell density, and these patients are less likely to experience progression of their disease. Treatment has also been shown to improve the quality of vision after implantation of multifocal lenses, as shown by Dr. Donnenfeld. And using a topical corticosteroid that is friendly to the ocular surface provides a tool to rapidly reduce ocular surface inflammation and also works synergistically with cyclosporin. This year, we also have a new option for as an immunomodulator, and that's Xider or lifitegrast, which is approved to treat both signs and symptoms of dry eye disease. This is a LFA1 antagonist, which is first in its class, and it works by blocking the interaction between LFA1 and ICAM1. So this helps to prevent the release of those inflammatory cytokines. So traditionally, evaporative dry eye disease has been treated with warm compresses, meibomian gland expression, artificial tears, prescription drops such as azithromycin off-label, or even oral antibiotics like doxycycline. But compliance has been a problem because these treatments are usually ineffective. Let's go into the next slide. And the reason why they're ineffective is because these conventional treatments don't address meibomian gland obstruction. So LipiFlow thermal pulsation treatment is one of the treatments of choice when there is evidence of meibomian gland dysfunction and compromise to the meibomian glands. It's the only FDA-cleared treatment for evaporative dry eye disease. Data is showing that if we start treating these patients and intervene in an earlier stage of their disease, then they're going to respond better than if we wait until their glands are atrophied and non-functional. This is a very safe treatment option for these patients, and there have been multiple recent long-term peer review papers demonstrating long-term efficacy of one 12-minute treatment. Next slide. So I'd like to just present this case. This was a 75-year-old patient that was referred for a cataract evaluation, complaining of intermittent blurred vision, burning, eye fatigue. Next slide. And as you can see, her ocular vital signs were a mess. She had very few secreting meibomian glands. She was very symptomatic, as evidenced by her SPEED score of 24. Her meibomian gland evaluation score just confirmed very few meibomian glands that were functioning. Her score was 4 in the right and 1 in the left. She had an unstable tear film, as evidenced by a reduced tear breakup time, and she had an abnormal tear osmolarity and a positive MMP9. Next slide. Pre-op Ks were unreliable, so we delayed surgery to really optimize her ocular surface. And as you can see in this topography, it's a little bit irregular. You can see dry spots, so this is an excellent way of demonstrating a poor quality tear film. Next slide. So we started the patient on re-esterified omega-3 supplementation. She underwent bilateral thermal pulsation treatment and then returned for repeat measurements approximately 1 month later. Next slide. So again, 4 weeks after starting her on the omega-3s and treating her with thermal pulsation. Her eyes were more comfortable. As you can see with this low speed score, she started out at 24 and she's now at 2, so she's pretty much asymptomatic. She has more functional glands secreting meibomi, and the quality of her tear film has improved, as evidenced by improved tear breakup time, and she also has better quality Ks and topography. Next slide. So you can kind of see in this, go ahead and click on, there we go, that her Ks were more reliable compared to pre-treatment. Next slide. So treating her ocular surface changed our treatment plan. Initially, we were going to place a spherical crystal lens. After treating her ocular surface, her biometry suggested placing a toric or a true line crystal lens, which is a 20, instead of placing a crystal lens, we actually chose to put in a true line. So the patient ended up very happy with 20/20 distance and intermediate with a plano refraction. Next slide. So dry eye disease before and after cataract and refractive surgery is extremely common and is underdiagnosed. It decreases our surgical predictability and can adversely affect our surgical outcomes. So it's critical to have a high index of suspicion of dry eye, even in asymptomatic patients. And I also really, try to encourage clinicians to don't hesitate to delay surgery until the ocular surface is healthy enough to generate accurate measurements. And again, I started recommending omega-3 supplementation, the Riosterified form, as a primary therapy for dry eye disease. And patients are motivated to take them because they know that it's going to help their eyes. They know that it's going to help to, obtain more reliable measurements. And there's also other multi-systemic benefits of taking a good quality omega-3. So again, with that, I'm going to conclude my presentation and pass the baton over to Dr. Gross. And I applaud Dr. Gross for all the work that he's done with nutritional supplementation. He probably knows more about omega-3 nutritional supplements than anyone I know. So again, Dr. Gross.
Wow, well, thank you, Alice, and what a thrill and a pleasure to have Dr. Epitropoulos start the show, lead the presentation, and I just for a second was thinking how wonderful it must be to be one of her patients. So compliments to you, Alice, because it just listening to you made me feel so warm and fuzzy, and also the way you present data is wonderful. And of course, I see that we have many folks with us tonight who are old friends and a great number of new ones. And thank you all for the superlative attendance that we have tonight. And many of you have seen my presentations. And next slide, Sarah, if we could go on. Our methodology of presenting has evolved to the point where we can talk about using omega-3s as part of your surgical protocol. But this is where ophthalmologists live, sleep, eat, and breathe, so we know the evidence has to be very powerful. And you just saw it and saw how beautifully it serves as an adjunct to your surgery. And of course, having Dr. Epitropoulos as our lead investigator and endorser of this product as part of the way she does things, there just couldn't be a better way to validate what we're doing. So, well, next slide, please, Sarah. This is why I'm talking to you and where my journey began. You all know it, but if you don't, I'm a perinatologist. I'm not an ophthalmologist. I was fortunate enough to be able to go back to school and get some graduate degrees in nutrition. And what I learned there was how much I didn't learn in medical school. And even to this day, our medical students and our trainees, residents, doctors, we still get very little nutritional training, but hopefully that's changing now, and of course everyone eats. So it's almost impossible for me to imagine now that I had so many conversations with high-risk pregnancy patients and didn't talk to them about how their diet was impacting their pregnancy. But that's changed now, and even the OBGYNs are embracing this now, and that's because we have a unit of measurement that is used throughout the world. The only place where nutraceutical is not definable is the US of A, and that's because the FDA does restrict nutrition in terms of curing, preventing, treating, or ameliorating disease, and yet everyone eats. So I would just invite you all to look at the definition of a nutraceutical because it's almost identical to a pharmaceutical, and that is when we take a component of nutrition, dose it properly, create it properly, and use it over time, we can get a predictable outcome. Now that's the difference between a nutraceutical and a supplement. No one knows what's on Costco shelves or in GNC and so forth, but we can create pharmaceutical equivalency when we follow the definition of nutraceutical that you see here. Next slide, Sarah. Dry eye disease may be the most ubiquitous disease in the world now. I'm not sure how many millions there are. This slide comes from Dr. Donenfeld, 1 out of 7. That number continues to go up. Next slide. And the face of dry eye is changing as well. It's becoming a problem of younger and younger populations, which sort of follows along with my theory that this may have an impact from our diet and other environmental situations, and that may begin from the time we begin to eat. But we certainly see that the dry eye compass is moving down into younger populations. Next slide. And why we're here is not because of me, really. When I went out and started pounding the pavement, it was for the cardiovascular benefits, the joint benefits, and so forth of omega-3s in the right form and dose. But that started about 2004, 5, 6. And then in 2009, I got a call from Frank Bucci, someone you all may know. And he said, Mike, I saw you somewhere, perhaps it was on TV, I was doing some of that work, and I started using your arthritis product, which was Flex Omega Benefits at the time, and found that it was the single best product I ever used for post-op LASIK dry eye. And you all know in 2009, LASIK was very much the rage. It still is, but the premium was there. It was a much more expensive procedure, not commoditized as much as it is now. And the issue of post-op dry eye was there, but not really being recognized. But Dr. Bucci figured it out, and he said, Mike, can't we change the name of your product from Flex to something else? And so I said, Frank, we'll call it anything you want. Just tell me, what is dry eye? I had never heard of that, and I think it was still a syndrome back then, not identified as a disease. And the exact same formula which we were using for our arthritis product, which we still have, is our dry eye Omega Benefits product. Next slide. Now the number keeps rising. If we include the undiagnosed population, and now that we have some really good tests for dry eye, we see this number going up and up, 55 million, 60 million, 70 million, but this is a serious situation, and it also may be reflective of inflammatory disease in general, but I won't go there now in this lecture. Next slide. So the next guru for us was this gentleman in the upper right corner, Greg Smith, who you all know, just like Dr. Bucci, a former Lindstrom Fellow, one of those geniuses that you all have in your field, and you're all among them. And of course that includes Alice. But Greg started using our product and also got terrific results for his surgery, and thank you, Sarah, for advancing that. So Greg called us up and said, listen, I'm having spectacular results with your product. Can I do some studies on it? And of course we said yes. And his first study was a cohort study of his own patients. And here you see it. And one more click, Sarah, I think, and we'll have the full slide there. So what you see here that was different was I asked Greg to include the Omega Index, a systemic measure. Actually, it is the first test where plasma, which is not as reliable a source or a measure of omega-3 levels, but actual presence of omega-3s on cell membranes. So this was red blood cell membranes as a proxy for all cells. So this is a really accurate measurement of the omega-3 levels in your patients, and that's the third bar that you see there. And sure enough, as the omega-3 index reached the magic number of 8%, you'll see about, why that's so critical in a second. But Greg hit these endpoints that Alice replicated in her wonderful study, and no one had ever hit these endpoints collectively. So, of course, we wanted to publish this, and it wasn't IRB at the time, but Greg said, hold it, Mike, there's a potential for intellectual property and patents here, so hold your horses. Next slide, Sarah. So what Greg did was go to the Cornea Society. Now we're up to about 2011. And if you all have been to the Cornea Society, you get a short amount of time to present there, 8 minutes. And we were number 14. The first 13 presentations were all about various treatments for dry eye. And then Greg got up and presented that little study that you just saw. If you move the forward, Sarah, you'll see the study as it was presented at the Cornea Society, and as Greg presented it, and at the end of his 8 minutes, he said that I now have over 500 patients using this product as monotherapy for dry eye. Now, of course, he used the other things, but it does take a while for nutrition to work, but when he said that word monotherapy, all the air seemed to go out of the room. And this was initially referenced. Of course, anything in the public domain cannot be patented, so it was referenced in this peer-reviewed journal, and you see the product mentioned there for the first time in print. Next slide, Sarah. Then Greg repeated the study, ran it through the IRB, this time also looking for mechanism of action, and he actually followed the pathway that Marion Massai had set with her omega-3 study. She was much more robust. She actually used 6 grams of flax oil. It just was the wrong omega-3. She didn't get her endpoints, but she was on the right track, and she did assay the MIBOM, as Greg did at baseline. And what he found was that at baseline, the MIBOM was omega-6 dominant, in other words, inflammatory. But at the end of 8 weeks in his study, the omega-6s had gone down 6-fold, and the omega-3s had gone up 5-fold using this product, and those endpoints were reached. So now we not only had the what, but we had the how and the why, and you'll see the value of that in a second. Next slide, Sarah. And that second study was also loosely referenced in this article, but we don't need to use these articles anymore because we have Alice's study, which is right there in the bullseye. Next slide, Sarah. And we had our first patent issued, it's about a year or so ago. The only patent, this includes pharma or Nutra, which is about quality of MIBOM. Composition patents, however, are a little easier to get because you can change them just a little bit, and it's not the same composition. So in commerce, people are easily able, sometimes if they want to get around composition patents. But here's the first one for quality of the MIBOM, and still is the first and only one. Next slide. So now the why. Why does our product work? You've already seen the what's going to happen. Next slide. And it's about therapeutic dosing of EPA and DHA, not fish oil, and in the right form. Next slide. And this has to be measured some way. So the Omega Index test was approved in 2009. It's a finger stick test. It doesn't require CLIA or blood draw, and it is a measure of omega-3 saturation on red blood cell membranes as a proxy for cellular levels in the body. Next slide. And the company that owns the intellectual property here is Omega Quant. It's Dr. Bill Harris, perhaps the world's expert. He's a biochemist and a physiologist, but he is a professor of medicine at Stanford University, South Dakota. He did create the Omega Index test, and you all can get it, and Sarah's going to make that possible as much as we can for you and your patients. Next click, Sarah. And what he showed there is, I'm sorry, Sarah, if you would back up just for a second. The red zone is the people who are at highest risk for a certain something that I'm about to show you. The green zone, when you're above 8%, lowers a very significant risk. Now, Sarah, if you would advance. And you'll see that in order to get into the green zone, 8% or higher, you need 1 to 3 grams of EPA, DHA, and triglyceride form daily to get to that level. And you could take carloads of flax oil, but it'll never get there. It doesn't work. But sure enough, $850 million of flax oil was sold last year for omega-3 benefit, but it really has no omega value. Next slide. And here is the astounding endpoint that Dr. Harris reached, a 90% reduction in cardiac death in the year of testing, a 90% reduction. So when you get your dry eye patients to this 8% level for their dry eye that Alice showed earlier, you're also helping them not to die. The endpoint here is survival. What a wonderful side effect to have with dry eye therapy. And of course, this applies anytime we reach 8% for any clinical purpose or any clinical endpoint. Next slide. The bioavailability was actually studied by Dr. Jorn Dyerberg, if you'll move this forward. Of course, that means how much is getting into the cells. Dr. Dyerberg is the father of omega-3s. He's the guy who lived with the Eskimos and to see why they were so healthy in Greenland. They didn't get heart disease and so many of the other things, in spite of the fact that you don't grow crops on a glacier. They got all their food, and they still do, from the ocean. And it seemed that a marine-based diet was enough to make them very healthy. And the omega-3s in those fish were, of course, in marine form, which is triglyceride form. He was asked by, at the time, Reliant Pharmaceutical, but became GlaxoSmithKline, to compare an equal dose of reesterified triglyceride, which is pristine fish form omega-3, against Lavazza. Next slide. And what he found was that in equal dosing, and the baseline was the unpurified fish oil, that the reesterified triglyceride was much more bioavailable and absorbable than Lavazza in equal dosing with no side effects. Anyone who's ever seen the side effect profile of Lavazza or wants to look at it, I think you'll be astounded, but it is FDA approved. And of course, in nutraceutical land, we don't have the billions of dollars to run through the FDA, although I will tell you at this moment that Dr. Smith is running this product through FDA trials. Next slide. And using the omega index as our metric, we also proved that an equal dose, or this was not us that proved, other study, randomized controlled trial, that a reesterified triglyceride in equal dose, next clicks, Sarah, next two I think there are, equal dosing will get you faster, quicker, and more safely to an 8% level in the omega index than an equal dose of Lavazza. Next slide. Now we have something that, this is a brand new slide. There was a study recently you've all seen that suggested that perhaps krill oil is better than fish oil for dry eye disease. Here's the study. Next slide. In fact, if you really look at that study, what you see was the study arms were very limited with the krill study, not as robust as Alice's study. The tear breakup time statistical significance was much better with the fish oil, okay? As you see, 0.004 is the fish oil, and as compared to this is 0.02, which they just hit it. And here's what's missing. The dose that they used in that study was a good dose, and that's why they were able to get to their endpoint. But krill oil is very expensive to extract, and that's why they have to say it's better, because if you were using therapeutic dosing of that, it would cost a fortune. So there you see the cost comparisons of their dose, not mentioned in the study. It would be $239 a month to use the dose they recommended in that study. And is it really better, or is that just marketing? Next slide. Dr. Dyerberg also looked at this. So again, the godfather of omega-3s did a white paper analysis of krill oil, which is phospholipid omega-3, against reesterified triglyceride, and found that there really was no difference other than the cost. So these things that you're hearing about krill are marketing things. They're not scientific things. There are no really good studies to show, other than the one I just showed you, that equal dosing is better. Other than that, but you can see if you go up to, and you want to get an omega index of 8%, and you won't find that on any krill website. You want to get to 8%, it's going to cost a lot of money to get there, because essentially the bioavailability is the same. Next slide. So what we try to create with our product, not only the scientific efficacy, but pharmaceutical equivalency, without the FDA imprimatur, because we don't have the millions and billions of dollars that it takes. So at this point in nutraceutical land, that means NSF and CGMP. NSF means at the factory where this is produced, there's independent third-party inspections of all the products and the oil, so that what's in there is what's in there, and it's pristine, and every bottle, every thing that comes out of that factory is third-party inspected with a number that's on the product that we give you. CGMP is an FDA certification of good manufacturing process, so we have these two designations, and we're very proud of that. This is as close to pharmaceutical equivalency as you can get, and this is why we've taken the extra step to go the route that we've done, and to have you all feel comfortable with our product, and why we don't go direct to consumer, because we're not a consumer product. We don't want to be confused with the things on the shelves. They don't do this. They're not equivalent. I don't know what they are. And our product turns out to be the lowest cost per therapeutic dose, yet when consumers shop for price, they only see a price where they could buy hundreds of fish oil products much less expensively, but they get no benefit from that. They would have to take dozens of those things a day, and it wouldn't be cheap anymore, and it would also be harmful. Next slide. So we're proud to have experts like Dr. Epitropoulos and Dr. Donenfeld that recommend our product and take our product as well. So here's another example of that. Next slide. And Greg Smith, who always dazzles us with his information and how he uses it for surgery, here is something that he showed us with his iTrace technology. Now here was a person, a LASIK candidate, prior to surgery, prior to omega-3 treatment. You all know this stuff better than I do. You can see the lack of clarity and how funky that corneal surface is. Next slide. And you can also see how aberrant and how all those red bars and stuff telling us that that cornea is inflamed and needs some treatment. So next slide. Here now is the patient's corneal surface prior to surgery. And as Alice said, the tear is the first refractive surface. Look at this improvement, and that last E on the top is really what the patient is going to see. And next slide, Sarah. And you can see all of the aberrant metrics on that corneal surface have disappeared just with treatment with omega-3s. Now, I don't want to discourage anybody from doing surgery, but this particular surgical candidate, after the omega treatment, chose not to get the LASIK because they were seeing so well. Next slide. So in the cataract population, similar situation. You've got a huge issue of dry eye disease in the cataract population, and this study, which was done back in 2010 to document some of the things that Dr. Epitropoulos mentioned. Next slide. And the FACO study was also mentioned by Alice. It's now up to 2011. And here's Bill Trattler and some of his colleagues showing that you better really pay attention to that ocular surface. If you make one more click, Sarah, you'll see that even back in 2011, he was recommending postponing or delaying the surgery, in this case 2 weeks, until you had the ocular surface under control to give you, your patient and yourself, of course, a better outcome. Next slide. And a refractive surprise, what a wonderful metaphor that is. I learned that from Alice and from Dr. Matosian. This is obviously what you don't want to have happen, and as Alice so beautifully articulated, by getting that ocular surface under control before you do your measurements, you avoid refractive surprise. Next slide. And now we're going to show you some more of why this approach is so monumental, more of the why, because so many of these patients that you're seeing have as their major component of their dry eye disease meibomian gland dysfunction. Next slide. You know this inside and out. The lipid layer is what we're talking about. That's what is impacted by the meibum, but of course, that lipid layer is the windshield, if you will, of the tear. And why tear osmolarity is so crucial in all of this, because without a normal lipid layer, it exposes the aqueous layer to evaporation, and definition of osmolarity is increased concentration of electrolytes in a fluid. So obviously osmolarity goes up, but if I've got good meibum, I have a functional lipid layer which protects all the layers beneath it, mucin layer, goblet cells, and all the rest. Next slide. And as Dr. Lemp showed us in his study, 86% of all of your patients, regardless of the form of dry eye disease or whatever their diagnosis or subtype, they will have a meibomian gland component. Next slide. So how does it affect your surgery? Next slide. Of course, as Alice so beautifully mentioned, if we don't have this under control before we do the surgery in some way, then we're going to have a lot of refractory surprise or whatever you call that. I guess that's it, refractive surprise. And you're also going to have a lot of uncomfortable people, very similar to what was going on back in 2009 with post-op LASIK dry eye. Unhappy patients because their dry eye, which was there preoperatively, was reactivated by the surgery. Next slide. Now here's something very recent that came out of the ESCRS, September 16, 2016. If you click on, hit that, Sarah, dry eye disease, dry eye symptoms is now the #1 complaint, just like the LASIK surgery following cataract surgery. This is what they're seeing in Europe, and I don't know if it's been studied yet in America quite this way, but obviously there's a lot of unhappy folks who didn't have their ocular surface disease managed before they had their surgery who are complaining post-operatively. Next slide. So again, more of the same. You know this is common, and we have to deal with it in some way. So next slide, Sarah. What we're suggesting, of course, is to avoid a situation like this. I got this slide from one of you all. We don't want anybody pointing the finger at anyone, but when patients are unhappy, they're going to point the finger at someone, and we don't want that to be you or anyone else. Next slide. So we have now this wonderful study that Alice did, and by the way, because we are limited in terms of finances and whatever, and we can't have the thousands of patients that pharma does in the study. So these endpoints were achieved with much less numbers than pharma would do, and yet we hit statistical significance to a much greater degree. Pharma, as you know, they're happy if they get a 10, 15, 20% clinical change after thousands of patients. But we did this with 50 patients, and that's pretty impressive. And this study was accepted by Cornea back in September after a lot of hard work by Alice and Eric Donenfeld and others to push this through into a publication. Next slide. So here we go in Cornea, where it was published in September 2016, and what we're so proud of even today, it just coincidentally happened to be the same issue and the same journal that the Epitropoulos study was published in, and amazingly, this study is still the #1 most read study out of that particular issue of that journal. And the second is the Zidra Epitropoulos study. So I don't think any nutraceutical study ever rose to this level of interest, and that's why we're talking to you now from a different platform than we used to. Next slide. And here's what we're most proud of. This method patent, which was issued about 6 months ago, this is really hard to do, and Greg Smith and I, this is what Sarah was referencing earlier, we actually had to go to Washington and take like a board exam, because when you have a method patent, you can control a lot of commerce, so the patent office is very reluctant to give them, but we do have this, so it's not only what's going to happen, it's how, and these method patents are very, very difficult to get. So we're most proud of this patent, which was issued about 6 months ago. So we have both a composition and a method patent. And I want you to know that over 50% of the drugs that you recommend to your patients that are in the PDR do not have method of action patents attached to them. Next slide. So where does this all go? It goes to the DREAM trial. And you may know about the DREAM trial, but if you don't, I know you're all familiar with AREDS, and that was a nutraceutical study done by the National Eye Institute actually twice, and it was done for the purpose of perhaps reducing the financial burden of payments for people with advanced macular degeneration, and also perhaps offer them another option. And remember that AREDS is only for advanced disease, of preventing further progression, and that group of supplements or nutraceuticals or whatever we want to call them reduced advancement of severe disease by 25%. So interestingly, we are in the last year of a very similar study also being done by the National Eye Institute called the Dry Eye Evaluation and Management Trial. And in this trial, they're using 3 grams of a rheosterified triglyceride form in a 2-to-1 ratio. And the results of this will be, at least the study itself will be completed in August of this year. And we're all waiting to see what happens. But this study actually was done in a smaller form by Penny Asbell. And we know what the outcomes will be. And it validates what we've already proven in our study. And of course, our patents control this form. So it's thrilling to be in this position to have validation of what we've done by the National Eye Institute and basically the government as perhaps, once again, a nutraceutical approach to dry eye will be elevated at least as high as some of the pharmaceutical approaches. Next slide. So in terms of surgical planning, I'm sorry there's not a, maybe it's coming, but I did want to show you something. I hope it's in the deck. But we know that it takes longer for nutrition to work. So we recommend this as adjunctive therapy to the drops and the scrubs and all the other things that you do to get the ocular surface under control. But at the end of the day, in terms of long-term therapy, as Craig Smith found and Alice and so forth, in terms of long-term therapy, to keep that ocular surface under control and to keep that wonderful outcome that you've created through your surgery, this may be the only modality that you need to use. But preoperatively, we'll leave it up to you how much you want to delay in terms of your preparation of the eye. Next slide. Prior to surgery, Dr. Donenfeld has created, and we will, as you hear from Sarah, we will help you create materials around your surgery, brochures like this. And here's Dr. Donenfeld's example that he uses at Ophthalmic Consultants in Long Island. Next slide. And if you click on this, Sarah, what you see in the preoperative is what Dr. Donenfeld says, which most of his colleagues are embracing, and that is to use the omega-3s as soon as possible preoperatively. But postoperatively on the right side, those other things that are done to ameliorate pain and so forth from the surgery ultimately drop out, and that all that is needed in Dr. Donenfeld's protocol for long-term therapy is the PRN dry eye omega benefits. Next slide. Oh, unfortunately, I didn't have it, but what I did want to I'm sorry I don't have the visual on this, a slide that we just prepared today. But Alice's study hit 5 clinical endpoints. There is no other study, either pharma or Nutra or anything, where this many endpoints were hit collectively. That includes Restasis and includes Xiidra, not in any way to denigrate them. There were wonderful studies and all that, but Xiidra, I believe, hit 1 sign symptom, and Restasis hit 1 symptom. But the 5 endpoints that you saw there have never been hit collectively before by any other approach, and we're very proud of that. And I'll conclude with that and let it go to Sarah.
Thank you so much, Dr. Gross, and thank you, Dr. Epitropoulos. Those are wonderful presentations, certainly very informative, and I'm sure many of you have some questions. What we'll do is I'll provide my email address at the end of the slide deck, and feel free to email over any questions you may have, and I'm sure both Dr. Epitropoulos and Dr. Gross will be happy to answer. All right, so to conclude the evening, we'll just review the few steps involved in optimal practice integration. And many of you may already be recommending PRN, but for those of you who aren't and are interested in getting started, here's how you could do so. So at PRN, we refer to our recommending doctors as partners in health. And through this partnership program, you have the ability to recommend these nutraceuticals, which are exclusively available through a physician recommendation. We've partnered with some of the leading ophthalmologists to provide their patients with optimal nutrition care. And our doctor-directed delivery program, or the 3D program, is a non-inventory model that removes the sales process from your offices, which really simplifies the recommendation process. Through this direct-to-patient delivery model, we strive to make it simple for your patients to follow through with your recommendations. We provide you with tools to support your recommendation of this PRN product, and we also offer a unique service of dedicated product advisors that could help educate and guide your patients through the ordering process. Your recommendation could include a very brief but yet precise message that includes key topics that highlight the specific nutritional regimen. For instance, for the dry omega benefits, you can mention that it's a patented product and it's a proven omega-3 formulation that isn't available over the counter. It's really as simple as that. And then you could provide your patients with a sample and a brochure and either direct them to call us directly, or better yet, you could send through a quick referral so a product advisor can follow up with them promptly. We make these HIPAA-compliant electronic referral forms that are specifically customized for your practice available to you, and it takes less than 30 seconds really to send in patient referrals. And here are some of the handouts that are available to your practice. We have samples and various brochures that could help educate your patients on this specific recommendation. Now, our product advisor program has proven to be extremely effective since this team is dedicated to reinforcing your recommendation and message by providing education on omega-3s and the PRN difference. Their goal is really to answer all of your patients' questions and guide them through the ordering process. So they serve as an extension to your practice. With this program, we've achieved outstanding rates in patient adherence and compliance. About half the patients that speak with one of our product advisors generally complete their doctor's recommendations. And on many occasions, this number is as high as 60 to 70%. Our message is focused on enhancing the patient experience to improve compliance as well as achieve and support not only their ocular health, but their general well-being as well, like Dr. Epitropoulos and Dr. Gross mentioned this evening. And we really stand by the efficacy of our product. So we do offer a money-back guarantee to anyone that takes the dry eye omega benefits as directed for 90 days. If they don't experience any symptom relief, then we will offer them a refund. So you can really confidently tell your patients to just take the dry eye challenge. Here you have our product pricing. Again, since our research has shown that it takes about 12 weeks for symptom relief, patients are recommended to get started with an initial 3-month supply, which is what you see here. So we do also offer discount pricing on 6 or 12-month orders. Now, as you heard this evening, there was some great evidence that shows the importance of oral omega-3 nutrition integration for optimal surgical outcomes. And again, our priority is to ensure a seamless integration into your existing practice flow. So over a brief training session at your office, we will introduce key practice and patient education resources to help with your recommendation. And like Dr. Gross mentioned at the very end, with his example of Dr. Donenfeld's brochure, we do offer customization of pre- and post-op brochures. We could integrate into an existing piece that you have. And this is really, again, to really help educate your patients on the importance of nutritional care for an optimal tear film before and after surgery for long-term maintenance. So again, we do recommend highlighting the benefits of omega-3s for the immediate tear film care and long-term tear maintenance. And we can work with your staff to support them in delivering this message and answering any questions that may come up from patients. And finally, I'll quickly review our products. I know many of you may already be very familiar with them. Here you have the dry eye omega benefits, which is, of course, indicated for ocular surface inflammation as well as tear film care. And it's available in capsule form, which you see here. This is 120 soft gels. This is a 30-day supply. And the recommended serving size is 4 soft gels daily. And these can be taken all at once or 2 at a time, twice daily with meals. This is also available in a liquid form, and this is a wonderful alternative for any of your patients that have difficulty swallowing or just choose not to take the product in capsule form. So the serving size is only 1 teaspoon daily, and this has the equivalent concentration of EPA and DHA as the capsule. So great alternative. Once this bottle is open, we do recommend refrigerating it, but again, a wonderful alternative to the capsules. And lastly, although our focus tonight was mainly on our dry eye formulation, I wanted to just mention quickly our macular health products. We have 2 of them. The first one is the Eye Omega Advantage, which you see here. And this is indicated for any dry eye patients with a risk or family history of AMD. The daily serving for this one is also 4 capsules daily, and it can be taken in the same fashion as a dry eye, either 2 at a time, twice a day, or all 4 at once with meals. And again, here you do see a 30-day supply. And finally, our AREDS 2 Plus formulation, which is our macular vitamin. And this is for your patients with intermediate to advanced macular degeneration. And the serving size for this one is 1 tablet twice daily, again with meals. And that really concludes our presentation for this evening.